All right, another good psych concept here is anorexia. So when do you need to actually hospitalize a patient with anorexia? And you would do that if their pulse is less than 40, so they're very bradycardic, they're hypotensive or lightheaded, and if they get orthostatic changes, that's another indication. And of course, if a patient is severely hypothermic, you want to admit them and warm them. And one of the things that is testable in more ways than one is refeeding syndrome. So if a patient with anorexia gets refeeding syndrome, look for dysrhythmias, severe edema, and electrolyte abnormalities. The electrolyte abnormalities is key. So the treatment here is going to be IV thiamine plus PO phosphate replacement for the hypophosphatemia prior to starting feeds. And the low phosphate is a huge clue for refeeding syndrome. If you know that, you'll get it right. And remember, a normal heart rate, 60 to 100 beats per minute, can signify impending cardiac compromise in a formerly bradycardic anorexic patient. This is similar to normalization of the CO2 in a really severe COPD patient. If a patient has a BMI of less than 15, then technically that is a book answer reason to admit them for anorexia. And if they're suicidal or psychotic, then definitely you want to admit them as well. But the ones that are tested most commonly is going to be a very severely bradycardic patient, somebody that has orthostatic changes, or they have refeeding syndrome. Number 12, let's talk about alcohol use disorder treatment. So you want to look for an elevated GGT or an AST to ALT ratio greater than 2:1. These patients will have psychotherapy as the next best step, plus or minus naltrexone. And remember, naltrexone is an opioid receptor antagonist that reduces cravings and binge drinking and can be started while they're still drinking. So you want to avoid it if they have a history of hepatitis or end-stage liver disease, but you can still give it to them if they have alcohol abuse history. And remember, acamprosate is a medication that can block the glutamate receptor and also can be used for alcohol use disorder. If a patient is withdrawing from alcohol, on the other hand, what do you want to do? Well, you want to give them vitamin B1, which is thiamine, magnesium, vitamin B12 and B9, IV fluids, plus dextrose, and a benzodiazepine taper. They love throwing that benzo taper in there, so look for something like chlordiazepoxide as an answer choice. All right. So chlordiazepoxide, aka Librium, is a long-acting benzo that used to be used more for alcohol withdrawal, but it is not used as much anymore in real life due to active metabolites causing a long mechanism of action. So I will say that even though it used to be used more commonly in the past, and now people will use lorazepam, aka Ativan, more often, I have seen chlordiazepoxide tested way too many times to not memorize that. And so lorazepam is safer because it has a shorter half-life, and it's safe for patients with liver disease because unlike chlordiazepoxide, it does not have active metabolites that cause a very prolonged mechanism of action. And an important thing to also note with alcohol use is for the alcohol screening, cage questions are not the initial step anymore. So your screening question should be, how many times in the last year have you had 5 or more drinks in a day, or 4 or more if a woman? So cage questions used to be the next best step for alcohol screening, but now you just straight up ask them. Number 14, if a patient has aggressive behavior plus 8 hours of symptoms plus nystagmus, what are you thinking? Well, that should clue you into PCP intoxication. The aggression plus nystagmus, this is somebody that's like trying to throw desks around, or they're like jumping on top of cars. You're thinking PCP intoxication. And the treatment here is if they're really aggressive or at risk of hurting themselves or others, you want to give them lorazepam. Like we said, lorazepam is essentially Ativan. And if mild symptoms of detachment or withdrawal and they're not aggressive, you just put them in a low stimulation environment and let them wear off the high. Number 15, if a patient is greater than 65 years old and they have a fall, what's the next best step? Well, you want to discontinue any mind-altering medications such as benzos or opioids. All right, and the action potential mentoring test-taking tip is don't be tricked by selecting physical therapy or giving them a walker or anything like that, because if they have a medication that is clearly psychotropic, that's assumed to be the reason why they fell on your board exams. So if you discontinue all the mind-altering medications, then you could say physical therapy is the next best step. But if they're on something that's psychotropic, you want to stop that and see if that improves their balance. Here's another test-taking tip. If you stop a short-acting benzo, such as lorazepam, you want to watch for withdrawal symptoms for the next 1 to 2 days. Your next best step, if they withdraw, can be diazepam or another benzodiazepine with a longer half-life so they can wean easier. And recall, naloxone is going to reverse opioids quickly. All right. Number 17, in patients with severe pain, such as a patient that's a trauma patient or a post-operative patient, but they have a history of opioid addiction, how do you treat their pain? Well, the treatment is going to be to max out their non-opioid pain management and then consider opioids if they still require additional pain management. You do not withhold opioids for somebody with severe pain, but you should have a thorough patient discussion on the risks and benefits of using opioids with their history of abuse. So you want to give them the NSAIDs, the Tylenol, do a nerve block, gabapentin, anything like that. And if that's not enough to control their pain, then you can progress to trying something like buprenorphine, which has a lower euphoria risk, which can be helpful in patients with a history of abuse. And something that's a good ethics integration for opioid use disorder is failing to treat a patient's pain is going to violate beneficence, and you never want to do that. So treat their pain if they have it. Number 18, let's discuss postpartum blues versus postpartum depression. This is a commonly tested fact. Postpartum blues is usually going to peak at 5 days postpartum and will resolve within 2 weeks. On the USMLE, you can be more confident that it's postpartum depression if it lasts over 2 weeks and it meets MDD criteria. So they have to have at least 5 of the Sig-E caps. All right, and then for postpartum depression, you almost never want to select the answer choice that dissuades the patient from stopping breastfeeding. Make sure you know that. The treatment is going to be an SSRI, such as paroxetine or sertraline. And then postpartum psychosis, you always want to select the answer choice that includes hospitalization, always. So if it resolves within 2 weeks, you're thinking postpartum blues. If it takes more than 2 weeks and it sounds very much like depression, it's meeting the Sig-E caps criteria, then you want to treat them with an SSRI such as paroxetine or sertraline. Let's talk about the different levels of psychiatric support that you can have. So there's inpatient psych hospitalization, and that's for patients that are suicidal or severe intoxication or in danger of hurting themselves or others. And if they have increasing symptoms or they live at home with a drug abuser, do not recommend outpatient rehab. This would be better for them for inpatient drug rehab. They need to have a good support system and motivation to do outpatient rehab. So basically, if it sounds like they have a sketchy home life or something that they're not comfortable with because they have a drug abuser in their house or they have very readily access to drugs at home, then these patients would do better with inpatient drug rehab. Number 20. Physicians must break mental health confidentiality for minors if they are at risk of serious harm to themselves. That's the one time you do it. And so the next best step is to inform parents or guardians if they're at risk of harming themselves. Here's a test-taking tip. Simply living with a family member does not make the other family member their guardian. Thus, you must tell their parents. Don't be tricked by this. Don't be tricked by a patient that is living with a friend or living with an older cousin or somebody like that. You want to tell their actual guardian, which is going to be their parents.